Assalamu alaikum everyone. Today our topic of discussion is Pheochromocytoma and Paraganglioma. Before starting Pheochromocytoma, I would like to discuss the physiology of catecholamines, that is epinephrine and norepinephrine. Basically, the sympathetic nervous system is regulated by these two hormones or the neurotransmitters, that is epinephrine and norepinephrine. Norepinephrine is formed and secreted mainly by the sympathetic ganglions or the sympathetic nervous system, while the epinephrine is mainly secreted and formed within the adrenal medulla. Norepinephrine stimulates the alpha receptors. After the stimulation, it causes the vasoconstriction, that is constriction of the blood vessels, and increases the blood pressure in this way, while the epinephrine basically stimulates the beta receptor as well as alpha receptors. By the alpha receptors, it has the same function as the norepinephrine, that is vasoconstriction. By the stimulation of beta receptor, it causes vasodilation, which is opposite to the vasoconstriction, means dilatation of the blood vessels as well as increase in the heart rate, that is tachycardia, increases the heart rate, that is tachycardia, as well as the insulin resistance. Due to insulin resistance, it causes hyperglycemia. This norepinephrine, which is formed in the sympathetic ganglions, it can be converted into epinephrine within the adrenal medulla by COMT enzyme, which is catechol O methyl transferase. Now come to pheochromocytoma and paraganglioma. Pheochromocytoma is basically a rare tumor which arises from the chromaffin cells or the pheochromocytes of adrenal medulla. If this is extra adrenal, that is, if it arises from the sympathetic ganglions of the sympathetic nervous system, then it is called paraganglioma. This is very rare tumor which secretes, produce and store the catecholamines, and due to this tumor there is excessive catecholamines, that is epinephrine and norepinephrine levels are becomes very high in the blood. Now come to the clinical features of pheochromocytoma. The most important clinical feature is hypertension. This hypertension is very severe. It may be persistent or it may be episodic. It may be persistent or episodic because of sympathetic over discharge in the body. And the second feature is it may happen in some patients that postural hypotension may develop. Why this postural hypotension may develop? Because of the episodic attacks of hypertension, natriuresis and diuresis. Natriuresis and diuresis may occur, and which causes postural hypotension, that is sudden droppage of blood pressure when the patient changes its position from sitting to the upright position. There is a droppage of blood pressure by changing the position, that is 20 millimeter reduce in the systolic blood pressure and 10 millimeter reduce in the diastolic blood pressure when the patient changes its position from sitting to the erect upright position in the standing position. And the third important feature is severe headache. This is very important and common feature of pheochromocytoma. This feature is because of hypertension. When there is a sudden attack of hypertension, severe headache may develop because of hypertension. And the fourth important feature is tachycardia, that is increase in the heart rate. When the heart rate is greater than 100 beats per minute, this is called tachycardia. And the next feature is diaphoresis. Severe diaphoresis or severe sweating is also an important feature because of sympathetic overstimulation in case of pheochromocytoma. And palpitations. What is palpitation? It is basically the feeling unpleasant sensation of patient's own heart rate or on its own apex beat. This is called palpitations. And the next feature is anxiety or impending dooms. And the non-specific features are abdominal pain and constipation because of sympathetic over discharge. And because of insulin resistance, glucose intolerance may develop. In the lab's finding, you will get the hyperglycemia, hyperlipidemia because of insulin resistance, while hypokalemia is because of when there is a overstimulation of beta receptors in the sodium potassium ATPase pump in the skeletal muscles. When these sodium potassium ATPase pump gets stimulated in the skeletal muscle, there is a more influx of potassium into the cell, that is intracellular shifting of potassium, which leads to decreased potassium in the ECF. so it causes hypokalemia. Remember the rule of 10 in case of pheochromocytoma. It is 10% familial, it is 10% occurs in the children, it is 10% occurs bilaterally, otherwise it is unilateral, and in 10% cases it is multiple, otherwise it is solitary, and in 10% it is extraadrenal, that is paraganglioma, and in 10% it is malignant, otherwise in 90% of the cases it is benign tumor. Now come to the diagnosis or investigations of pheochromocytoma. The screening test we perform in case of pheochromocytoma is urinary metabolite test, urine metabolites of catecholamines, urine metabolites of catecholamines, that is metanephrine, vanillyl mandelic acid and normetanephrine. But this test is not that significant because of its false positive result. We get the false positive result in most of the cases because there is more levels of metanephrine and normetanephrine and vinyl mandelic acid in stressful conditions, in acute illness, and in severe exercise. These are the various factors which increases the levels of metanephrine and normetanephrine in the blood or in the urine. So may get the false positive results in the screening test. But the next gold standard test or the superior test is plasma free metanephrine levels. Plasma free metanephrine. This is a more superior and more significant test than the urinary test. And the next test is chromogranin A. This is also a tumor marker. It is raised in non-functioning tumors of adrenal gland. And the fourth test is anatomical localization. We can get the anatomical localization by a CT scan or the MRI of the abdomen to localize where actually the tumor is. And the next is functional localization. This functional localization is done by scintigraphy. In this test we inject the patient's blood with MIBG, meta-ido-benzyl guanidine, and this is a dye which is absorbed by the pheochromocytoma tumor, and when it is absorbed then perform the gamma scan to localize functionally localize where the actually tumor is. Now come to the management or the treatment of pheochromocytoma or paraganglioma. The most important treatment is laparoscopic adrenalectomy, which is performed in case of pheochromocytoma. But before this adrenalectomy, give the patients alpha blocker at least 6 weeks before this surgery. Alpha blockers like phenoxybenzamine. This is non-selective alpha blocker. Phenoxybenzamine. This is non-selective alpha blocker to control the BP, to reduce the blood pressure. But the major side effect of alpha blocker is relative tachycardia. This alpha blocker causes the severe vasodilation, and due to this severe vasodilation there is increase in the heart rate. That is, relative tachycardia may occur by giving the patient alpha blocker. So give this patient 2 or 3 days before surgery, give this patient beta blockers like propranolol, and this propranolol will help to reduce the tachycardia. Always remember, don't give the beta blockers before the alpha blockers, because if we give the beta blockers before the alpha blockers, it causes unopposed alpha mediated vasoconstriction, which further increases the blood pressure. And the second important step is during surgery, when there is a surgery is going on and blood pressure is raised because of anesthetic induction, give this patient nitroprusside, which is also a vasodilator, as well as you can give the patient phentolamine, which is also alpha blocker, in order to control the blood pressure during surgery, which may occur because of anesthetic induction or which may occur because of metastatic spread of the tumor in the circulation. And the most important treatment of choice is laparoscopic adrenalectomy. But before adrenalectomy, we prepare the patient with these antihypertensive drugs and then perform the laparoscopic adrenalectomy. Thank you so much for watching this video.